Hello, I'm Professor Nicola Specchio, and I'm consultant neurologist at the Bambino Gesù Children's Hospital in Rome, Italy. Together today, we will discuss the disease state of Lennox-Gastaut syndrome, with a particular focus on the Japan and the Gulf countries. LGS is really one of the most severe form of developmental and epileptic encephalopathy, starting with the child having a childhood onset. In the great majority of patients, seizures are difficult to control with anti-seizure medications, and drug resistance is relatively the rule. We do know that about 20% of children with seizures starting in infancy may evolve to Lennox-Gastaut syndrome. And we have, in terms of clinical manifestations, we have some seizure-specific symptoms and non-seizure symptoms. On one side, we have tonic seizures, atonic seizures, atypical absences, and tonic-clonic generalized seizures. On the other side, what I would like to underline and put really to stress today is the occurrence of non-seizure symptoms, which are commonly seen in 100% of patients, and are developmental delay, intellectual disability, and other type of behavioral disorders, psychiatric issues, motor impairment, and other multimorbidities which affect those patients. You know that there is a profound impact on both patients and caregivers. And if you look the story from the side of patients, there is a burden on patients which is relatively related to the high seizure burden, to the non-seizure symptoms, to the polytherapy. Polytherapy gives to those patients a really, truly high burden, and in terms of also of side effects, the multiple comorbidities that we just mentioned, and social isolation. And on the other side, we do have the caregiver burden, which is definitely really relevant for the management of those patients. And we have the physical problems that are associated with the care, the financial burden, and similarly to what is experienced by patients, the social isolation and reduced quality of life for both patients and caregivers. There is a complex presentation, and there may be resource barriers that may contribute to the diagnosis challenges. So on one side, I would like to mention that there are some core features, and the clinicians should investigate LGS patients looking at the core features which have been published recently from the ILE Terminology Commission. And you have the three major are the cognitive or the developmental impairment, the multiple drug-resistant seizures, and the presence of a specific EEG pattern with slow spike wave discharges or the fast activity during sleep. There are some recommended diagnostic tools and from the ILE, and there are some features which we consider to be mandatory and some others that are optional. And you have the clinical evaluation, EEG, and the optional MRI and genetic testing. So now I invite my fellow faculties, Professor Yamanouchi and Dr. Alzadi, to answer some questions from a pre-canvassed target audience on the disease state of LGS. So how do patients with Lennox-Gastaut syndrome present in your region?
I'm Hideo Yamanouchi. In Japan, the real-world data show that children with Lennox-Gastaut syndrome typically experience their first seizures at around 1.6 years of age, and median age at the confirmed diagnosis is approximately 4.2 years. This highlights the diagnostic delay of several years despite the early symptom onset. At the time of the first consultation, tonic seizures were reported in 96% of patients and myoclonic seizures in nearly 40%. In addition, about half of the patients presented with learning or intellectual impairment as a non-seizure symptom. By the time data collections, virtually all patients had developed impaired verbal communications, reflecting a progressive impact of the disorder. Importantly, prior to receiving a confirmed diagnosis of Lennox-Gastaut syndrome, over 90% of patients had initially been given another seizure-related diagnosis, most commonly general epilepsy or general seizures. These findings emphasize that in Japan, maybe as in other regions, Lennox-Gastaut presents early, but diagnosis is often delayed, and both seizures and non-seizure symptoms create a high disease burden for children and their families. Thank you.
Thank you very much, Hideo. That's very interesting data from Japan. Let's move now on to Tafik, please. Can you comment on the same question?
Thank you, Nicola. As you know, that LGS is not a static disease. It's always a disease in evolution. So the presentation is the function at what age the patient is presented in the clinical setting. We have only one study in our region that came from Iran, which was based on a retrospective cross-sectional chart review study that included close to 300 patients. Across all the cohorts, obviously the majority of them had presented with developmental disability. The seizure type is again the function at what age these patients had presented. For instance, a patient presented below the age of 1, you find most of them, 2/3 at least, would present with tonic seizures. Half of them would have myoclonic seizures. On the other hand, if they present between the age of 1 and 7, you can find half of them would have tonic-clonic seizures, 2/3 will have tonic seizures. On the other hand, if they present above the age of 8, again, tonic seizures seem to be present in at least half of those cohorts. However, about 80% would have tonic-clonic seizures. So it's really the function at what age these patients would present to. This is the only study that we have in the region. Obviously, we're hoping to have more studies in our region so we have better understanding how this LGS present in the Gulf region.
Thank you, Tafik. That's very interesting, actually, and it's the huge number of the study sample is very big. So interesting data. Thank you very much. So how do you apply the LGS diagnostic criteria in the clinical practice, and which tools are most commonly used in your region?
Yes, as far as I know, our standard approach begins with clinical evaluation and developmental assessment combined with EEG. The hallmark features we look for are a slow spike and wave discharges and paroxysmal pulse activity during sleep. MRI, as mentioned, Specchio said, MRI is not required for the diagnosis, but we usually perform it to investigate an underlying etiology. I think this is very important. We now also incorporate genetic testing in selected patients, particularly those with very early onset or typical features. One important lesson from recent studies, including IEC, as he mentioned, IEC 2025 reports is that many patients previously labeled as Lennox-Gastaut syndrome do not meet the stricter ILA criteria, mainly due to the missing overnight video EEG. So high qualified EEG monitoring is, I think, is very crucial. Thank you.
Thank you very much. That's very relevant regarding the diagnostic criteria, which are now divided into mandatory, alert, and exclusionary, and it can be very helpful for clinicians around the world.
Obviously, the ILE Task Force on Nosology have done a wonderful job on putting on the criteria that help all clinicians to making a good diagnosis on LGS. The problem, at least in our region, in the Gulf region, is the variability of care. So in some settings where you probably have an access to video AG recording, then you can probably apply all the criteria that had been previously outlined, and you can make a good basically diagnosis. On the other hand, in the other setting where you may not have an access to video EEG recording, so you probably have to rely on surface EEG recording, and I'm not so sure by itself the surface EEG recording lacking of the video EEG recording, so you can get the night recording, you can make the best diagnosis of the LGS. However, in the most setting, the diagnosis is based on clinical grounds, the fact that these patients present with multiple seizure types, the issue of obviously cognitive impairment, developmental delay. These are the features that most physicians in our region would rely on to making that a presumptive diagnosis of LGS. Again, unless we are in a setting where you have an access to video EEG recording, which is available in only a very few centers across the Gulf region. But certainly, this is a work in progress, and we hope that we can apply these diagnostic tools in a better way in the Gulf region, provided obviously we have the resources that will allow us to make the best diagnosis in that regard.
So, what is the extent of diagnostic delay both in Japan and in the Gulf region? So, Hideo, would you like to start with Japan?
Yes, thank you. My point is early and accurate diagnosis is essential because it allows us to tailor treatment strategies sooner. Delays often lead to prolonged use of effective medications, unnecessary side effects, and additional burden for families. More importantly, cognitive outcomes and quality of life are strongly influenced by how quickly we control seizures and optimize therapy. Data from, as you know, Pilar Garza and colleagues and recent IEC findings reinforce that diagnostic delay is a major barrier to better long-term outcomes, I think.
Yeah, thank you. Excellent. What about from your side, from the Gulf region, Taufik?
Unfortunately, we do not have any data in the Gulf region that address that question.
Yeah.
So we have to rely on some other data from elsewhere. And I'll quote here a study, for instance, that was published in the state based on an international survey that reported a variability between the time from parent observed symptoms to receiving a formal diagnosis of LGS. And in that regard, you can find at least a third of these patients would have to wait at least up to 5 years before the accurate diagnosis can be made, and then about 28% would have to wait more than 5 years. So clearly there's a variability in the literature. Unfortunately, in the Gulf region, we do not have any good data in that regard, but my expectation from anecdotal experience, it certainly can take up to several years before patients can reach an accurate diagnosis of LGS.
That's very true. That's very true in so many countries. Thank you very much. So let me move now to the another point, which is related to the strategies which you believe are most effective in supporting timely identification of patients.
Well, basically, these tools are quite helpful in making probably an easier diagnosis of LGS. Obviously, there are several screening tools have been developed, including the REST LGS tool that is based on 8 criteria, 4 major and 4 minor. They can probably help you in identifying patients with LGS. Obviously, these criteria have been recently modified and to make it more practically applicable. So definitely these tools and similar other tools that had been available in the literature can be obviously helpful for busy clinicians to making a better and easier diagnosis of LGS in that regard.
Thank you very much. And also, I would like to point out that there are some also data coming from the International Epilepsy Congress recently happened in Lisbon 2025 on diagnostic checklist. And there are a couple of interesting abstracts on diagnostic checklists. So let's go quickly to the last point of our talk, our discussion today, guys, which is related to the impact of LGS on patients and their family, and how much this varies in your region.
According to our study that is presented on last year's Japanese Epilepsy Society 2024, in Japan, the impact of Lennox-Gastaut syndrome extends far beyond seizures. Real-world data show that half of the patients already have learning or intellectual impairment at their first consultations, and by the time data collections, 100% had impaired verbal communications. This illustrates the progress and severe non-seizure burden of Lennox-Gastaut syndrome. The burden on caregivers is equally striking. The study indicated that the parents may spend up to 50 hours per week providing direct care, and nearly half report significant stress, sleep problems, or anxiety. Families also face financial strain and social isolation as a result of consultant demands of care. Our encouraging aspect in Japan is the presence of strong patient associations and specialist networks. Many families report emotional relief and improved coping once they are connected to these support systems. This shows that psychological support can be just as valuable as medical treatments as addressing the overall burden of Lennox-Gastaut syndrome.
LGS is a big hit on the patients, the society, the caregivers, and it can have definitely devastating outcomes. It certainly there's only one data that came from our region came from Gus Baker that was back in 2005, looking at specific at individuals impacted by LGS, and in at least half of those patients had been affected at multiple domains in their overall life, in the standard of living, relationship with families, etc. But in that study, it failed to address other issues that these patients are affected by, including their reactions in the society, how they fit in the society, how the caregivers are affected, and the overall economical and other burdens in the society as a result of that disease state.
Thank you very much, Taufik. Thank you very much, Hideo. Great discussion, a lot of topics on the table, and thank you very much to all the attendees. Hello, I'm Professor Specchio, and I'm consultant neurologist at the Bambino Gesù Children's Hospital in Rome, here in Italy. Together today, we will look at the current approaches to the clinical management of Lennox-Gastaut syndrome in the Gulf region. And also, we will explore the specific challenges and the opportunities in this region. And let me start from the anti-seizure medications and the non-pharmacologic management, which in the last few years have reduced significantly the seizure burden for patients with Lennox-Gastaut syndrome. There are different drugs that are currently used for the treatment of Lennox-Gastaut syndrome. Some of them are even off-label, and they moving from clonazepam to felbamate, lamotrigine, topiramate, and rufinamide. But the most recent are the cannabidiol and fenfluramine, the last two approved from the both EMA and FDA. And there are some non-pharmacological management strategies which include ketogenic diet, VNS, and more rarely deep brain stimulation, resective surgery, which is something that is very rare, and calosotomy. The understanding of anti-seizure medications is relevant in patients with the different etiologies of Lennox-Gastaut syndrome, as far as we need to look at the mechanism of action of those drugs. So moving to the sodium channel blockers, to the GABA mediated inhibition, or modulators, so presynaptic release machinery, or some drugs which have mixed mechanism of action, which is again interesting to use as far as we are always looking at a single drug with the multiple mechanism of actions. Now we'll review very briefly some data which has been published at the International Epilepsy Congress in Lisbon in Portugal in September 2025 on the two most recently approved drugs, namely the cannabidiol and fenfluramine. So on one side, it's interesting to mention that CBD treatment is definitely linked to seizure reduction in patients with Lennox-Gastaut syndrome. But what is also very much interesting is that it's been nicely reported an improvement of caregiver global impression of change, both on patient side and physician side. And there is also a significant indirect effect of CBD treatment on CGI caregiver global the caregiver side. Another interesting point is that there is a reduced anti-seizure medication cycling, the polypharmacy and seizure-related physician at 12 months after the initiation. And these are very interesting data showing that after starting CBD, there is a significant reduction of new anti-seizure medication per patient. And also there is a reduction of change in polypharmacy and a reduction in the healthcare resource utilization in both adults and children. And lastly, I would like to mention briefly that there are two interesting abstracts regarding fenfluramine. One is on the fenfluramine exposure and reduction in seizure frequency. And what has been nicely documented that there is a significant relationship between the fenfluramine and norfenfluramine exposures and reduction in seizure frequency, which is definitely something that we need to keep in mind. There were no relationship evident between fenfluramine, norfenfluramine, and the association of two, and the maximum decrease in the platelet count. If you look at the mixed effect of the fenfluramine and norfenfluramine, there are no significant differences in other parameters outside seizure reduction. And lastly, another important and relevant point is again on the CGI, which interestingly show that both in the open label extension study, there were both on the caregiver perspective and the investigator perspective, more than 85% of them considered the patients improved or at least no changes. Lastly, I would like to mention that as European physicians, there has been done a survey showing that physicians are quite aware of risk minimization measure, which are associated with fenfluramine, and there are some of those which are very much known around physicians in Europe, including materials, educational material from talking about fenfluramine, including the frequency of echocardiogram, which is done in patients, and other needs that patients with Lennox-Gastaut syndrome may have taking fenfluramine. So now I will turn to our panel of experts from the United Arab Emirates and Saudi Arabia, Dr. Tawfiq Al-Sadi and Dr. Rahid Al-Baradi. So how is the LGS currently managed in the Gulf region, and what are the treatments commonly used in the clinical practice?
As you know, management of Lennox-Gastaut syndrome is really challenging in general, either in Gulf region, Saudi Arabia, or other areas. But the treatment recommendation from Saudi Arabia Council of Health Insurance, Epilepsy Child Health Insurance Formulary reviewed in 2023, the first line is sodium valproate. And this sodium valproate is considered for boys or men and women who are not in the childbearing potential. Next come a second line is lamotrigine, and it can be used as monotherapy or add-on therapy. Followed in the third line, various anti-seizure medications such as clobazam, cannabidiol, or in combination with clobazam for patients more than 2 years. If all options fail, we can consider other treatment options such as felbamate, and we need to be aware that certain medication can make it worse, such as carbamazepine, gabapentin, lamotrigine, oxcarbamazepine, phenobarb, pregabalin, as well as vigabatrin. So we have to be very, very careful about this, using these medications.
Thank you very much, Rahida. Very comprehensive. And Taufik, could you go please and moving to the non-pharmacological recommendations from the Gulf region?
I mean, the only data that come from the Gulf region come from Saudi Arabia, and that data suggests other methods can be considered, such as ketogenic diet, or provided that you have an access to an epilepsy specialist. There's also data on the use of vagus nerve stimulator as well. And the data that looks at specifically about the use of ketogenic diet, that Raida was part of that study that was done in Saudi Arabia. They looked at the tolerability effectiveness of 77 pediatric patients in that region with a history of genetic epilepsy syndrome. Some of them had a diagnosis of LGS. In that study has suggested that the seizure outcome after the ketogenic diet had significantly improved in at least 93% of those patients who had tried on the ketogenic diet.
Thank you very much. That's very interesting. So now let's move again on a second question, which is related to the factors that you consider when selecting treatments for individual patients with Lennox-Gastaut syndrome.
Obviously, the management of LGS should not be different from any other epilepsy syndrome, except for very few exceptions. The treatment should be individualized, taking into consideration several factors. One is related to the patient's factor itself. You have to remember, though, those patients oftentimes have other comorbidities, so you have to take those into considerations before you offer treatment. Some of these patients obviously had sleep disorders, sleep problems, aggressiveness, behavioral problems. So those should be looked at carefully before you suggest whatever medication. You have to look at the seizure type, predominant seizure type, the frequency, severity of these seizures to advocate the best treatment for those patients. How familiar as physicians we are with these medications in order to offer these different types of treatment. And cost should be definitely an issue, and the access to medication, because not all medications are equally or uniformly available across the GCC region. Some are not in different parts of the Gulf region.
Excellent. Thank you very much. And what about Rahida, about the guidelines that he used to guide treatment selection?
Yeah, as you know, in Saudi Arabia, we don't have specific guidelines. We always refer to American Epilepsy Society and Japanese Society of Child Neurology guidelines. There are like guidelines that we usually adapt and modify according to the availability of the medication based on these two guidelines. For example, lamotrigine, topiramate, trofinamide are established effective in treating Lennox-Gastaut syndrome based on clinical experience. Clobazam is also established as an effective treatment for Lennox-Gastaut syndrome, and it is all FDA approved. Valproate, as you know, it is off-label, and new treatment algorithm is taken from Europe and other countries.
Yeah, thank you. And actually, yes, I can comment on the European treatment algorithm. I mean, this was recently published on Epilepsy Open, and you have an algorithm which is a slight modification of what was previously reported in 2017, having as valproic acid, lamotrigine, rufinamide, and then on a third line you have both clobazam and cannabidiol, fenfluramine and topiramate, almost at the same level, even if we know that for some of those drugs just mentioned, there are more real-world evidence rather than if compared with others. But that's interesting, and we know that several of our patients, they're taking both drugs. Even some of them, they're taking even both concomitantly, cannabidiol and fenfluramine. So let's move now and briefly, Tafil, can you briefly go to the US adult treatment algorithm?
Actually, the AS had put together the guidelines for the LGS patients who reach out to the adulthood life, and they put the medications according to their tier of evidence. So tier 1, basically recommending use of valproic acid, clobazam, lamotrigine, rufinamide, topiramate, or cannabinol. And for tier 2, levetiracetam, though it's off-label, perampanel, and zosonamide. And in tier 3, felbamate, lacosamide, brivaracetam, as well as cenobamate. But they are also making sure that certain medications should be avoided because they certainly can worsen some seizure subtypes, including carbamazepine, eslicarbazepine, gabapentin, oxcar, phenytoin, pregabalin, and vigabatrin. But they also emphasize on the importance of non-pharmacological options, ketogenic diet, VNS, calosotomy for those patients who are candidate, deep brain stimulation, as well as resective surgery for patients who are a candidate for that operation. But again, emphasizing that patients should not be only dealt because of their seizure type. We have to look at patients from a holistic point of view. So we have to provide them with the right education, the occupational therapy training, they provide them with the equipment to help them with mobility, etc., as well as to help them psychologically, because oftentimes these patients had other behavioral issues that need to be tackled as well. So this is what the US recommendations for those patients who reach to the adulthood life.
Now we'd like to discuss with Rahida about the key side effects which are associated with treatments with Lennox-Gastaut syndrome. And if you can briefly summarize what are the most relevant and what the people should look at. Thank you very much, Rahida.
Yeah, thank you, Nicola. The side effect of the seizure medication, as you know, it is divided into three. The first one could be acute, early idiosyncratic reaction associated with allergic mechanisms such as skin rash. It could be dose-dependent inhibitory action on the nervous system, like neurotoxic side effects, for example, dizziness, nystagmus, double vision, drowsiness, nausea, anorexia, cerebellar attacks, and psychiatric symptoms, or chronic phase adverse effect after long-term use of these medications, such as hirsutism, weight gain, or hair loss, or kidney stone, cerebellar atrophy, gingival hyperplasia. And we do have certain side effects based on certain medication. I will give you example, like cannabidiol. It can cause hepatic injury, somnolence, sedation, hypersensitivity reaction, and we have to be very careful when it is used with other medications such as clobazam. Clobazam can cause main problem such as somnolence, sedation, serious dermatological reaction, physical as well as psychological dependence, withdrawal issue after discontinue the medication that has to be weaned off gradually, as well as suicidal behavior and ideation. Fenfluramine, the main side effect is the decreased appetite and weight gain, especially in children's. It can cause also somnolence, suicidal behavioral and ideation, as well as increase in blood pressure, as well as glaucoma. Lamotrigine, it is one of the medications that can cause life-threatening serious reaction.
Thank you very much, Rahida. So let's move now on going toward the conclusion. So that's very relevant to me and this question. So what are the key challenges associated with treating LGS in the Gulf?
There's so much need to be done for those patients beyond seizure control. Seizure control is one aspect of the problem. We have to look at those individuals from a holistic point of view. We need obviously to provide patients, their caregivers, families with the information, the educational tools to let them understand the disease burden and how we can best treat them. We need to provide these patients with the best effective multidisciplinary team approach to manage them from all aspect, behavioral aspect, cognitive aspect, mobility aspect, among many others. Again, emphasizing on seizure control, we have to have an access to pretty much all the possible effective medication to have the best outcome and best quality of life for those patients in the best possible effective way.
There are also faculty-related issues, such as identify the specific patient, caregiver information need, navigation complex information, option risk benefit, coordinating with the multidisciplinary team input, as well as guiding patient caregiver through difficult decision and use of decision aids.
Great. Thank you very much. Thank you very much, dear colleagues. Hello, I'm Professor Nicola Specchio, and I'm consultant neurologist at the Bambino Gesù Children's Hospital in Rome, in Italy. Today, together, we will look at the current approaches to the clinical management of Lennox-Gastaut syndrome in Japan. And also, we will explore the specific challenges and opportunities in this region. There are different drugs that are currently used for the treatment of Lennox-Gastaut syndrome. Some of them are even off-label, and they moving from clonazepam to felbamate, lamotrigine, topiramate, and rufinamide. But the most recent are the cannabidiol and fenfluramine, the last two approved from the both EMA and FDA. And there are some non-pharmacological management strategies, which include ketogenic diet, VNS, and more rarely, deep brain stimulation, resective surgery, which is something that is very rare, and callosotomy. The understanding of anti-seizure medications is relevant in patients with the different etiologies of Lennox-Gastaut syndrome, as far as we need to look at the mechanism of action of those drugs. So moving to the sodium channel blockers, to the GABA mediated inhibition, or modulators, so presynaptic release machinery, or some drugs which have mixed mechanism of action, which is again interesting to use, as far as we are always looking at a single drug with the multiple mechanism of actions. Now we'll review very briefly some data which has been published at the International Epilepsy Congress in Lisbon in Portugal in September 2025 on the two most recently approved drugs, namely the cannabidiol and fenfluramine. So on one side, it's interesting to mention that CBD treatment is definitely linked to seizure reduction in patients with Lennox-Gastaut syndrome. But what is also very much interesting is that there's been nicely reported an improvement of caregiver global impression of change, both on patient side and physician side. And there is also a significant indirect effect of CBD treatment on CGI caregiver global, the caregiver side. Another interesting point is that there is a reduced anti-seizure medication cycling, the polypharmacy, and seizure-related physician at 12 months after the initiation. And these are very interesting data showing that after starting CBD, there is a significant reduction of new anti-seizure medication per patient. And also there is a reduction of change in polypharmacy. and a reduction in the healthcare resource utilization in both adults and children. And lastly, I would like to mention briefly that there are two interesting abstracts regarding fenfluramine. One is on the fenfluramine exposure and reduction in seizure frequency. And what has been nicely documented that there is a significant relationship between the fenfluramine and norfenfluramine exposures and reduction in seizure frequency, which is definitely something that we need to keep in mind. There were no relationship evident between fenfluramine, norfenfluramine, and the association of two, and the maximum decrease in the platelet count. If you look at the mixed effect of the fenfluramine and non-fenfluramine, there are no significant differences in other parameters outside seizure reduction. And lastly, another important and relevant point is again on the CGI, which interestingly show that both in the open label extension study, there were both on the caregiver perspective and the investigator perspective, more than 85% of them considered the patients improved or at least no changes. Lastly, I would like to mention that as European physicians, there has been done a survey showing that physicians are quite aware of risk minimization measure, which are associated with fenfluramine, and there are some of those which are very much known around physicians in Europe, including materials, educational material from talking about fenfluramine, including the frequency of echocardiogram, which is done in patients, and other needs that patients with Lennox-Gastaut syndrome may have taking fenfluramine. Now, I will turn to our panel of experts from Japan, Professor Nakagawa and Professor Yamanuchi, to answer some questions related to the management of LGS in Japan. What treatments are used for patients with LGS in Japan?
In Japan, the first-line drug is valproate. But for childbearing aged women, priority is given to other drugs. In the cases of valproate cannot be used, or valproate is not adequately effective, lamotrigine, zonisamide, topiramate, and rufinamide or levetiracetam is used. Clobazam is used for drop seizure, while etosaximide is used for atypical absence seizures. Do not use gabapentin or carbamazepine when treatment is difficult.
More recently, fenfluramine has become available, and which expanded our options for refractory cases. Unfortunately, cannabidiol is not yet available in Japan. Non-pharmacological approaches remain important, as you mentioned, and such as ketogenic diet and vagus nerve stimulations or callosotomy, particularly in children with persistent drop attacks. Multidisciplinary care, including physical therapy and psychological intervention, is also emphasized.
What are the factors that you guys consider when selecting treatments for individual patients with Lennox-Gastaut syndrome? And please, can you start again, Professor Nakagawa?
Selecting treatment for individual patient with LGS, first of all, patient-specific factors, age, comorbidity, treatment goals, aspirations, prevalence, and the goal of treatment should be optional seizure control rather than seizure freedom. And next, disease-specific factors seizure history, for example, frequency, severity, requiring the hospitalization, and treatment-related factors, line of therapy, what priority prior therapies the patient has received, and the side effect. So management of LGS must carefully balance the burden of treatment against its potential side effect, always focusing on the patient overall quality of life and physician attitude.
Thank you very much. That's very helpful and really a lot of insight. And then I'm moving to Hideo to answer this question about are there any guidelines or algorithms that you use to guide treatment selection?
Well, we do not have any special guidelines in Japanese Society of Child Neurology or Neurology, but I always prefer to the guidelines such as an European Lennox-Gastaut syndrome guidelines, as well as American Association of Neurology and AES treatment guidelines.
Yes, it's interesting that in the 2018, the Japanese Society of Neurology published these clinical practice guidelines for epilepsy, but it's not really, as far as I understood from you, it's not really related to Lennox-Gastaut syndrome. Yeah, that's interesting. So let me just briefly summarize the European treatment algorithm. In all the other algorithm, valproic acid is followed up by lamotrigine and rufinamide, and then you have as a subsequent adjunctive therapies, you have on the same level, you have clobazam, cannabidiol, topiramate, and fenfluramine, with some differences in terms of efficacy and safety, but this also due to the different limited the different numbers of the different experience we do have in real world evidence. We do have some the most frequently used drugs, which our audience will be very much interested to listen. What are the warnings and the precautions? Thank you, Hideo.
Yes. In my opinion, one of the important questions in Lennox-Gastaut syndrome is not only which treatments are effective, but also which side effects require special attention in this patient population. First, sedation itself is a major concern, I guess, and because many Lennox-Gastaut syndromes patients suffer from atonic seizures and frequently falls, and excessive drowsiness from inappropriate anti-seizure medications can increase the risk of injuries and further impair daily functioning. The second one is we need to be cautious about cognitive and behavioral side effects. Many children with Lennox-Gastaut syndrome already have a developmental delay and as well as intellectual disability. So drug-induced irritability, aggressions, or attention problems can have a disproportionately negative impact on their quality of life. And with newer therapies, we must also consider disease-specific safety issues. For example, for fenfluramine, the risk of valvular heart disease and pulmonary hypertension requires regular echocardiogenic monitoring, as I mentioned. And for cannabidiol, the risk of liver enzyme elevation is especially high, even used in combination with valproate. And this calls for careful laboratory monitoring.
Now, there are a further point that we may go into, which is related to the strategies to mitigate the challenges we do have in terms of both access to treatment, in terms of both diagnosis proposals. So please, Hideo, can you go through the recommendation of the Japanese Society of Neurology?
Yes, our challenges, as far as culture is concerned, our major challenges is timely recognition and referral. Diagnosis often are delayed, and especially outside of major urban centers. And another challenges is access to neuro treatment, and as approval timelines in Japan can lag behind Europe and or United States. And in Japan, there is a marked uneven distribution of physicians with doctors, particularly epilepsy specialists, and concentrated in urban areas, while rural regions face a shortage that lead to disparities in the level of care. So to mitigate these issues, the Japanese Society of Neurology recommends referral to specialized epilepsy centers when management becomes difficult, and emphasize structures patient educations, including formation about treatment, safety, and social support systems. As well, and the Japanese Epilepsy Society designate highly specialized centers as comprehensive epilepsy centers. At the same time, in order to promote more equitable and efficient epilepsy care, discussions are underway to enhance physician training to increase the number of epilepsy specialists and introduce appropriate telemedicine and AI technologies actively. Thank you.
Excellent. Thank you, Hideo. And let's go now on the quite briefly, just summarizing the epilepsy regional medical care system in Japan.
In Japan, the Ministry of Health, Labor and Welfare, MHLW, launches the National Model Project for Epilepsy Regional Medical Cooperation System development in 2018. The Japanese MHLW has designated NCNP. Our hospital NCNP has an epilepsy support center for this project. And the Epilepsy Regional Support Center established in 13 out of 47 prefectures. The goal is to promote transitional care for epilepsy patients in interactive and bi-directional support between pediatrician and adult physicians such as neurologist, neurosurgeon, and psychiatrist. The epilepsy medical support coordinator coordinate with patient families, welfare, medical care, and government in their respective area of expertise. And the goal is to help patients and their families improve their quality of life.
Thank you very much. That's very inspiring, and it's a very interesting how you organize the medical care related to epilepsy in Japan. I want you to comment on a couple of more interesting things like social stigma and transitions process. So please, can you comment on these?
Yes, thank you. To improve the social stigma around epilepsy, we try to consult with psychiatrists to promote these issues. That is one of the strategies. And as for transitions issues, I consult to the adult neurologist or psychiatrist for the transition issues.
So now let's go to into the last point, which is, of course, looking to the future.
Well, looking to the future, I believe that artificial intelligence will play an increasingly important role, not only in Lennox-Gastaut syndrome, but also in broader field of drug-resistant epilepsies. AI-assisted EEG interpretation can help identify characteristic patterns such as slow, spike, and wave, or paroxysmal pulse activity more quickly and with greater consistency. which may reduce the diagnostic delays. In addition, machine learning models that integrate clinical genetic and imaging data are being developed to support precision medicine, helping us to predict treatment response and tailor therapies to the individual patient. These advances will not replace clinical judgments, but they have the potential to transform how we diagnose and manage Lennox-Gastaut syndrome, moving us closer to truly individualized care and improved long-term outcomes. Thank you.
Thank you very much indeed. Very interesting points.